ALL is a disease that predominantly affects children, but it also, half of the patients are 18 years and older, all the way up to 85, 90. So that is the biggest difference. How we approach ALL is the age, and age has also a huge impact also on the genetics of the disease. We find certain genetic aberrations more frequently in younger patients, and we find more adverse genetics in older patients. So with that said, it really sets the pace how we treat the patients, and obviously a younger patient, particularly the children, can be treated very aggressively with a lot of chemotherapy. They have just a much better organ function, but then once you reach an age group that is beyond the age of 55, it clearly makes a big difference there that you have to reduce chemotherapy, and once you reach the age group of 75, chemotherapy is quite often not anymore a real option. So the cure rates in these patients really correspond to that, whereas in the pediatric setting with today's protocols, more than 90% are cured. Whereas when we use these more pediatric inspired protocols for the middle group, somewhere between 18 to 55, cure rates drop with every decade of age. And then once we get into the age group of about 65 plus, only about 20% of the patients might be cured, despite all the new modalities that we have. As an introduction, I am an adult hematologist, so my experience really is from the age group onwards, from 18 until 85, 90. So, and within that age group, age is the most important consideration. But then also, apart from age, we have risk stratifications based in categorizing patients to being in standard risk, high risk, and very high risk. So standard risk is everyone who doesn't display any risk factors. And then there's a set group of patients who have high risk, which means they have some cytogenetics that make them high risk, like the 411 translocation, or they have hyperleukocytosis. So then you would be boxing them into the high risk group, and the very high risk group are the Philadelphia positive patients in that situation. So also nowadays, we get as more information that we have a pH-like signature, which also has been shown in many cooperative groups of having a very adverse prognostic situation. So with younger patients, and young in this group means for me 18 to 55, we treat them with pediatric inspired protocols. So it is a very tense protocol using very much more elements from the pediatric-based protocols, and we try to get this therapy into the patients in this age group. And obviously, as patients mature, they also do have more comorbidities, like, for example, liver function might be impaired by previous other diseases, and that makes a difference which substances you have to use or can't use in that situation. So the other thing that we also do is we, based on the surface expression of certain antigens, like for example CD20, we would add immunomonoclonal antibodies, and that has shown by many study groups to be a very good approach to increasing the overall survival for those patients. So it is absolutely essential to get all this information very quickly, within days, to make decisions how you're going to treat the patient, because the cytogenetics, if they are, for example, Philadelphia positive, you would use very different induction regimens nowadays than the ones which are pH negative. So after pre-phase of 5-6 days, you would then straight away jump in the first induction there, and there we can really take a very different treatment approach for those patients. Cytoreduction is a very important question. Cytoreduction is done first for different age groups. So anyone beyond the age of 55, we would nowadays not expose them to the same strength of therapy than someone who is 18 to 55. And then there are comorbidities that would obviously also be important to reduce the therapy. And then if someone is pH positive, we clearly also do cytoreduction, because the data of reaching the first goal of getting patient to remission is as good as by using intensified chemotherapy with using just imatinib plus vincristine and dexamethasone in patients who are pH positive. So that is a very important key factor of making that decision when to cytoreduce.